Good morning. Today we're going to be talking about psoriasis, which is a skin condition not many people know about. Thank you, Dr. Ayesha, for coming on the program. It's a pleasure to have you with us.
Thank you very much for inviting me, Dr. Pamela.
Always a pleasure. So we're talking today about psoriasis. And, people are saying, so what? Psoriasis, what is psoriasis? And why is it you're interested in letting Nigerians know about it?
Okay, so psoriasis is a complex, chronic, multifactorial condition. It's an inflammatory disease that involves the skin, which could be the hair, the nails, and the skin, and the joints. And what does it do? It involves what we call hyperproliferation of the epidermis. And I'll break that down. It means that your skin cells are sort of shedding. So you have a quick increase in the epidermal cell turnover. So your skin cells take about 28 days to replenish, right, in the cycle. But when you have psoriasis, the turnover is every 3 to 5 days. And so you have a lot of shedding. Now, why we want to create awareness about this condition is that it's previously known in the Western world, right? It's said that, okay, in Africans, you don't have it. Yes, it is true. We don't have it as much. However, we are finding that over the years and over the last 2 to 3 decades, we're finding that we're seeing it a lot more than has been previously documented in Africans and in Nigerians in particular. And we have 2 studies, from the northern Nigeria and even a study we carried out in LUTH, where the prevalence was about 0.8% in the north. And then for us, it was about 1.13%. So we are seeing it more increasingly. Could it be that it's due to the change in lifestyle, lots of other factors, environment, things that are coming into play? Do we have an increased awareness because we have more dermatologists? No matter what we think, even though we say our healthcare is not the best, yes, and there are lots of issues, but the truth is it has been improving. We have a lot more specialists that we had 50 years ago when, the last studies on psoriasis were documented.
Well, I think that's actually very interesting. 2 things. One, that, obviously there are more specialists coming in, but 2, the fact that psoriasis is increasing. Because I recall even as a young person in dermatology, not seeing as much as when I came abroad to see how prolific, would I say, psoriasis is here. And there were some reasons why they gave that it was common in the West and not common in Nigeria. Things like they said, the weather and so on. But the weather hasn't significantly changed. So why would we be seeing an increase? I mean, what do you think are the reasons? Why is it more? Because even if you say the diagnosis is more because there are more dermatologists, but you yourself are seeing more cases, aren't you?
Yes, we are. I think there's an awareness, and the truth of the matter is it's a chronic condition. So a lot of people conceal it. It's under the body if you don't have the full-blown type of psoriasis. And you have people presenting saying they've had it for 10 years, 5 years, 8 years. So they have had it. But, maybe now there's a lot of, I think the technology era plays a part. And then post-COVID, technology era, which was already there, has increased because people just go online. They want to look for a dermatologist. Then they come, they seek you out and they're coming to you. And then when you hear, you'll say, oh, it's not a sudden thing. And so the more newer onset diagnoses are made by those who, are more internet savvy, IT compliant, and just relatives. Relatives will be like, no, I hear there's one place you can go to, there's dermatologists, there's this, there's that, So you're getting the newer onset individuals and then the older ones. Now, environment plays a key part,
Okay.
The environment, what's going on. So that we cannot specifically pinpoint what's going on. And there's a lot of studies that need to be done. Food triggers, not really, Food triggers alcohol, yes, they can exacerbate it, but the food is not implicated in the etiopathogenesis.
So why do people get it? What are the risk factors? People are listening now and thinking, I hope I don't catch this thing. How do people get psoriasis?
okay, you have a genetic background, definitely, you know. There's certain inflammatory conditions where there is a genetic predisposition. So you have some extrinsic, which means coming from outside, and then you have intrinsic factors that, you know, trigger psoriasis in a predisposed, genetically predisposed individual. So you have extrinsic factors such as stress, mechanical stress, trauma, air pollution. That's another part where I said, you know, with regards to the environment, we don't have, you know, studies and things like that. Drugs, vaccinations, antimalarials in particular. And, you know, for us, we do take this environment, we take antimalarial drugs quite, what's the word now?
Quite a lot.
Unnecessary, you know, we take it a lot, yes, you know, quite a lot, yes. Then you can also have smoking and alcohol, as I mentioned. And then from within you, the intrinsic factors, you have obesity, you have what we call the metabolic syndrome. So if you have a high cholesterol, you've got diabetes, you've got hypertension, those things all together with obesity make up the metabolic syndrome. And then stress. Mental stress. That
And there's
can
a lot
also
of stress
be a trigger.
right now. There's a lot of stress. So for those who have heard you, can you describe psoriasis a bit more? Because, you know, this is a radio show, so they're not seeing what psoriasis is. So can you describe it? How does it show? How does it present? What the kind of symptoms a person has?
Okay, so psoriasis presents like a reddened, right? So in someone with my complexion, of course, the red color is more obvious. But even with, you know, people who are a little bit darker, you see that sort of redness or a dark purple sort of going towards, you know, brown. There's this scaly lesion. It might start off at the beginning looking like ringworm, and that's actually how it would be passed off. And I have seen one or two psoriasis patients that I initially thought was ringworm. And of course, I've given them treatment. And then further down the line, 4 to 6 weeks later, I'm seeing that, you know, it looks different. And then suddenly they're even presenting to you. And what it has now come out, you know, in a more full-blown manner. And as soon as I see it, I'm like, oh, this is psoriasis. Meanwhile, it didn't look like it in the beginning. So it can present like that. So the key message would be, okay, if a doctor is treating you for ringworm, or you think it's ringworm, because ringworm is treated by everyone, and you've used treatments, and after 2 to 4 weeks, maximum 6 weeks, it's not getting better, then it isn't ringworm. You know, you need to look out for a dermatologist. Then you can have, you know, what you do is you have this sudden onset. You have the other type, which is called the guttate type. It appears like a shower. So you just have this sudden onset of tiny ringworm-like lesions all over your body. That's the guttate type. It could also be preceded by an infection. So you might have had a sore throat or a viral illness or something. So this rash that comes on after an illness and doesn't seem to go away, that's, you know, that could be psoriasis. There could be a bit of itching. Itching is not exactly always seen, but it can be found. Then with the nails, you find people with all their nails completely destroyed. Okay, it could start off looking like fungal infection of the nails, so you have a whitish discoloration as well. On the scalp, so you have lots of people who say, I always have dandruff, so my hair is falling. And the typical psoriasis patient can come to you with an envelope or something where they've collected the scales. So when they put their hair and they do that, you know, you find the dandruff in quote. So dandruff, which has been persistent, sometimes they can have bleeding spots. So you look at the lesion and there'll be pinpoint spots of blood. That is also, medically, it's called the Auschwitz sign. And that, you know, for us, tells us. So they, as the patients, will tell me, oh, sometimes I see tiny dots of blood. So that's for the scalp. And then the joints. After a certain time, the skin lesions, you start to have joint pains. So those are the various ways in which they can present. Then you also have a very bad one, which is called the erythrodermic psoriasis. And that's when you have almost over 80% of your body affected, and you're just shedding. You can't tolerate, you know, the cold because you've lost your, you know, your mantle of protection that the skin would give you. So they're shivering, they're very cold, they feel cold, they have a fever, they could have lymph nodes. With the lymph nodes, there would be inflammation in the affected areas. So when you check, there would be regional lymphadenopathy. You can also have the inverse psoriasis. This is where you have this psoriasis, you know, underneath the breasts. You can also have what we call genital psoriasis. Now this, it takes quite a while. It's usually missed because it's obviously in a very sensitive place. And, it will take a while for the individual to present. And when they do, they're now presenting to the doctor, and you just have repeated, episodes of the lesions in that area. So that is actually often missed and can actually cause quite a lot of discomfort. And of course, with married couples, you can well imagine, that occurs. So also the part of the awareness is for other doctors also to be aware, the general practitioners, about this type of presentation.
Thank you very much. Thank you, Ms. Abimbola, for coming on the program to share your experience with us. We really appreciate it.
Yes, ma'am, you're welcome.
So can you tell us about your experience? How did you find out you had psoriasis?
Okay. Firstly, I'll say it has been hell. But it all started by, let's say, 2010, 2011. I was still in secondary school then. But no one knew it was psoriasis. All what we were treated then was like eczema, maybe a stuff like that. But still, it was not going. Like, we used a lot, different herbs. It got to a point we thought it was spiritual, but everything still went like that, nothing. So I was like, okay, can my parents just take me to hospital? So it was when we went to the hospital, that was after then, because when it happened, it went for a while, like 2 years, so it came back. So when it came back, it came with like full force. The first time it was only on my leg. So when it will come back the next 2 years, it came my two hands, my elbow, it was everywhere. So we went to our family doctor. He gave me a cream then, Betnovate N. So it worked and everything was going smoothly. So it came back again. And when I used the Betnovate N, it was not working anymore. So when we complained, he referred us to LUTH at Lagos State. So when we went there, when I complained, I was told I would do a biopsy to know what was wrong with me. So it was after the biopsy, I was diagnosed of psoriasis. And even after then, I was not told it was psoriasis. That was like after then, it was like 2020. I went for the biopsy then. So when the results came out, I was just given drugs, some cream, and I was told to not use anything medicated, antiseptic, just anything mild and gentle for the skin. So when I got the drugs, I asked the doctor, like, what's wrong with me? She just said, it's nothing, it's just environmental stuff. So I used the drugs and everything cleared off totally. Like, if you should see me, you know nothing happened to me around that 2020, 2021. So I was supposed to go back for my treatment, like I had an appointment, but because it cleared off, I just neglected the appointment. I was not going again because though place is a little bit far, I'm based in Abeokuta, so I'm always going to Lagos State. So when it cleared off, I was just like, wait, I was gone, Jerry. So it was like after a year, it started coming back again. So when it came back, I went to get those drugs, same drugs that I was given to use. So but because some were scarce, especially retin A, yeah, retin A was very scarce. I could not get it. So I ordered it. I got the small tube. So when I applied it, it was not working again. So I had to go back to LUTH. And after then, drugs I've been using till now have not been that effective. I don't know. It has not been effective at all. Sometimes it might just go, but once I stop the treatment, it will come back. Maybe just let's say a week interval, it will come back again.
That's terrible. So how does it make you feel though? How do you feel in terms of are you able to keep relationships? How does it make you?
Yeah. Because yeah, I like my family has been there, my friends, no one has, though I'm always indoor. I only go out mostly nights. And
Why?
because, oh,
You just don't like it.
what do you say?
Why do you stay
No,
indoors?
no, nothing. I just feel like, some people just be like, what's this? Is this thing? Is this thing? Go and buy this thing. But I know what it is. So I just feel like, just trying to avoid questions. But my relationship with them have never stopped. Like, nothing happened.
Okay. So you don't
But it
have
has
any
just
issue
been, no,
with
no,
stigma or
no,
anything like that.
no,
That's good. But it's just
no, no,
been
no, no,
depressing,
no.
difficult for you.
Yeah, it's been difficult. It's been very, very difficult. Like, especially the itching, the like this stinging. I don't know. Yeah, it's been
Okay.
hell, but it's
Thank
fine.
you. Thank you very much for sharing your
Yes.
story with us. I would like to ask Dr. Ayesha. Dr. Ayesha, is this trend that Abimbola is showing, is it a normal trend?
Yes, it can be a normal trend. I did say to you that some of them would completely, have it in covered up areas, and they're just managing it because, maybe they've gone here, there, and everywhere and haven't got much solution. And so they'll just leave it. For some others, it will be temporary, a little bit of relief here, a little bit, so there is that trend. Then there are those that's really quite affected because of the extent and when it is visible. For Mr. Abimbola, I just had to reach out, because he wanted someone. So I had to reach out on our registry and reach someone, and I didn't have a chance to chat with him. But I can tell you for free that what most of these conditions require is a good 30-minute sit down to counsel the patient, let them understand what's going on, and give that extra support. We try our best in our clinic, and he would know that. However, we are limited. We are limited because our clinic is inundated with patients. We are short-staffed. Ideally, you should have a counselor, a nurse counselor, you could have an assistant, who does all of that. So many times, we're trying to catch up with the situation and make up. Do you understand? And I think that would be a situation whereby he wasn't counseled enough. Do you understand? To have that understanding. Today I was in clinic and I saw at least 4 follow-up patients, who are on disease-modifying drugs like methotrexate. So they already know the drill. And because, they've been told we some days you're able to offer more counseling than others. Could be a good day in the clinic when your patient load is not so high,
Yes.
So yes, sometimes, 1 or 2 people can be caught in between, but he's also mentioned his challenge, which is coming from Abeokuta. And remember that, we had the Lagos-Ibadan Expressway, you have to come down that way. So it has been challenging. When he thinks of that too, that will add to it, However, he's not alone, and we're always there as he knows. And so, we try our best to educate and increase the awareness. And then sometimes, when you've been using the drugs for a while, we need to switch. So if we haven't seen you, you know what I mean? Like he had a reoccurrence and naturally he tried to just continue with those drugs and it didn't work. We could switch the drugs. We might move on to something else. So those are just some of the factors that do occur, in this situation.
Okay, so right now, he has been very fortunate in terms of he doesn't appear to be experiencing much stigma from what he's describing. But his reluctance to go outside, is this a positive or a negative thing? Should he not be seeking sunlight?
It's definitely a negative. It's definitely a negative because he did say that, he doesn't want to go really because people will be like, what's this? Oh, why? And then, people offer, Nigerians, your pastor, your imam, your auntie, your uncle, your friends, everybody wants to offer a solution and say, oh, why don't you use this? Why don't you use that? So, and because he knows what it is, he knows that is, futile listening to people. But I think what can happen is just the continued relationship with the dermatologist. Psoriasis and dermatologist is a relationship which continues. We have psoriasis patients that we've had in the clinic for over 15 years, So that will be the plan, and hopefully get him into remission. And then we see him less often. And then if a flare comes again, he can come, So that's where we're at with psoriasis.
And you were talking about a registry. Can you shed some more light on this?
Yes. So
What is the
globally, there
advantage
is
of the
globally there is a lot of
advantage?
awareness of the registry. Yeah. So what you have is globally, they are able to give you all the figures. Here, we're not, mainly because, we don't have a lot of documentation going on. Some of our patients are lost to the GPs and elsewhere. So we're creating a registry. So we'll have people in the different zones, geopolitical zones, who are interested, our colleagues in psoriasis. So that at the end of the day, what we're doing is we're documenting. So each psoriasis patient we see, we plug them into the registry, we document their data, their clinical features, the treatments they've been on, their biopsy confirmation, so that at the end of the day, we are now able to say, we could do in 6 months' time, we could do preliminary reporting, 1 year, 2 years. But at the end of the day, we have this registry. Of course, we'll have to increase awareness amongst ourselves and then amongst GPs and other healthcare practitioners to the presence of this, registry, but more importantly, to help other GPs recognize. So there will be training and awareness, programs, so that they recognize it and refer to us. So that's what we plan to do. We also look at it in the next stage would now be doing some genetic studies, because at the end of the day, if we don't do genetic studies, we would not be able to document what we are seeing in Africa and amongst Nigerians. So we need to have some genetic studies so that we can move forward, with respect to treatment options and in terms of educating and creating awareness.
So can you give that, we have less than 2 minutes now, can you give a last word for the doctors who are listening to this program, and then also for the patients? What do you want them to know? Last words for our listeners.
Okay, so psoriasis is a condition that is an inflammatory disease. It is not a death sentence. It is not an infectious or contagious condition. If you're treating, it presents like eczema, it can present like ringworm. If you're treating an individual and you've been treating the person for whatever lesion it may be, and it's not getting any better, please seek out the dermatologist. There are a lot of us all over the country. In Lagos, there's at LUTH, we're at LUTH, there's at FMC, there's at GH Bagada, General Hospital, Lagos Island, and there are a few in private practice too. So that would be the first thing to the doctors. To the patients, we've got your back. We'll walk with you on this walk, on this journey with psoriasis. But we understand that, things like, I can't control the stress factors in Nigeria today. But I think if we can try and, now what we do is just give you a few, websites, tips that you can read to understand. So as an individual, Pamela, you help me out. How do I advise somebody to be, to take it easy in Lagos? Transportation, costs, blah, blah, blah. So all the other things. So these things do trigger our flares in our psoriasis patients. So as much as possible, is making them understand, when you're strong and you know what's going on, then you try your best in your own circle, and he has mentioned that he has his family and friends supporting, they know. So those are just the little things that we can do. But most importantly, follow up, come to us, so that we can help you and adjust the treatment. We do that. So, just because you've used one set of treatment option doesn't mean, sometimes, the disease can get a little bit worse. And so we want to use other drugs that are available. So Mr. A, we'll be seeing you in the clinic and we'll chat.
Thank you very much.
Thank you for watching. Please like, share and subscribe for new video updates.